Good morning. Thank you, Dr. Farber, for the invitation to come and talk about improving outcomes with infrarenal aneurysm ruptures and the endovascular treatment. My disclosures. So ruptured AAA still represents a common abdominal aortic emergency with an incidence of 6.3 per 100,000, or in the increased age population of 65 years of age, up to 35 per 100,000. It remains a considerable source of morbidity and mortality, with reported historic surgical mortality rates of 45 to 50%, and an overall mortality of 75 to 90% when in pre-hospital deaths and non-treatment patients are included. So EVAR has basically replaced open surgical repair for the treatment of elective asymptomatic AAA. Large prospective registries, multi-center trials for EVAR have demonstrated significant reductions in perioperative mortality, long-term aneurysm-related death, and EVAR has particularly increased benefits in high-risk patients. So it's natural that these two would collide, and so the endovascular treatment of ruptured AAA, which was first reported in 1994, since that time, numerous authors have demonstrated a decreased 30-day mortality with outcomes compared to open repair. Procedure times are decreased blood loss, decreased length of stay, including intensive care unit stays, and an average postoperative mortality rate somewhere in the 20% range on the initial reports. So endovascular repair versus open repair for ruptured AAA does remain controversial. There have been multiple single-center series and retrospective reviews, and recently a few prospective randomized trials. Now, I will not spend any time talking about those prospective randomized trials because a world expert on the subject will be talking towards the end of this session, and we're just going to let that up to Frank to take care of as far as going through some of these prospective trials. So what I'd like to focus on instead is the cornerstones of improving outcomes in the management of these patients. And that includes the introduction of the management protocols for ruptured AAA, principal permissive hypotension, introduction of specific endovascular techniques that were developed in other uses and are now very applicable in both endovascular and open repair of ruptured AAAs, improved anesthesia and postoperative intensive care therapy, and then early identification and management of abdominal compartment syndrome, which is a major source of morbidity and mortality in these patients even after endovascular repair. So I'm going to kind of sift through a lot of data. The first two studies I want to look at are with the introduction of management protocols. And the first was was published back in 2006. Dr. Mehta's group looked at 40 patients that were initiated into this rupture protocol and compared it to a control group of patients from before. This is their protocol, which you can see takes a major commitment not only on the part of the endovascular or vascular surgery team, but on the entire institution to have the resources, the hybrid room, and the supplies on the shelf ready to go. And what they were able to conclude is that by liberalizing the anatomic inclusion criteria, they were able to treat about 95% of these patients with EVAR. They evolved from a brachial to a femoral placement of an occlusion balloon, which was an important part of the evolution of this treatment. Bifurcated devices were occasionally converted to AUI devices, especially in unstable patients and when there was difficulty in accessing the contralateral gate. Excuse me, and abdominal compartment syndrome developed in about 18% of the patients. The overall mortality was 18%, 7 of those 40, and it was significantly higher in the patients who developed abdominal compartment syndrome. One of the, a subsequent publication by Dr. Mehta's group, the only real change in their protocol was that they were no longer doing cut downs prospectively. They were in hemodynamically unstable patients, they were accessing percutaneously and dealing with the groin access after the patient was stabilized. The next paper that really just supported the first Dr. Mehta's group was published in 2007, was out of Canada. It assessed 126 patients with ruptured AAA and compared mortality before and after a protocol. And again, they found a lower overall mortality after the protocol was introduced, from 30% down to 17.9%. When they compared all open repairs, both the pre-protocol and the post-protocol patients and the EVAR, there was a significant decrease in mortality, down from 28 to 5%. And unstable patients showed trends toward improved survival, not quite statistically significant, but definitely towards improved survival with EVAR relative to open repair. And so these unstable patients are the patients that we think may actually benefit the most from endovascular repair. And then comparison of pre-protocol surgery with open repair after the introduction of the protocol found no difference between the open repair pre and post. So this improvement was all due to the endovascular repair patients. This is an example of their protocol. Sorry about that. And the conclusions that they were able to draw were that a predefined strategy of management of ruptured AAA includes EVAR is associated with an improved mortality. EVAR may be particular benefit to unstable patients, and they should not be excluded from repair and or further trials. And appropriate patients with ruptured AAA who are undergoing treatment in experienced vascular centers should be offered EVAR as the treatment of choice. Next, along the list of these things that will improve, that have improved the outcomes in ruptured patients, is permissive hypotension. And without getting into all of the details of the studies that have been published on it, I think this is one of the less controversial and very well accepted principles that we now follow. And it's been confirmed even as recently as in the IMPROVE trial, one of the most recent prospective randomized trials. The interesting thing that the IMPROVE trial observed was that the lowest systolic blood pressure was strongly and independently associated with a 30-day mortality. And so the initial thought of keeping these patients somewhere between 70 and 80 millimeters of mercury may have been a little on the low side, and maybe we should be trying to keep these patients somewhere in the 80 to 100 range. With permissive hypotension, though, we know that it is effective. It does accomplish the principle of hemodynamic hemostasis or hypotensive hemostasis in a number of patients, and allows us time to get patients transferred from out of hospital and into the emergency department straight to the OR, sometimes also to CT. It's feasible in most patients. The most important thing is that you need to monitor mental status during transport. And active pharmacologic blood pressure is probably the only part of this that remains a little bit controversial. In some centers, there's active medical management to lower the blood pressure, and in others, the patient's normal blood pressure is just observed. It does require education of the pre-hospital staff for out-of-hospital transfers, and it definitely should be part of your protocol. So talking a little bit about some of the endovascular techniques, the most important is the rapid use of endovascular balloon occlusion. One of the first studies talking about that goes all the way back to 2002, but this is a study that looked at 12 patients that were treated with endovascular repair of ruptured AAA. All patients survived the procedure except for one. These were unstable patients where they were taken to the operating room and balloon occlusion was used to stabilize their blood pressure. Overall mortality in 30 days was 17%, and this is the example of the protocol that they use. If they had a positive ultrasound, and a systolic blood pressure of less than 60. The patient was taken immediately to the operating room, bypassing CT, and an occlusion balloon was placed. And then if the patient's angiography was compatible with EVAR, an EVAR was performed. If it was incompatible with EVAR, the balloon occlusion aided in the open repair by allowing a more controlled dissection. I misspoke, actually 7 patients had open repair, and 5 of these patients underwent EVAR. And this is an example of the rapid balloon occlusion. One of the most important things is that you support the balloon with a 12 or a 14 French sheath. And this is a spot film of that type of treatment. This is a little bit more detailed view of a patient of how you can use the balloon occlusion in a stepwise fashion, moving from one side to the other, going from the ipsilateral to the contralateral side. And just to go through some of this in a little bit more detail, when you advance the occlusion balloon from one side, in this technique, that becomes your contralateral side. You then bring the device up from the other side, and that becomes your ipsilateral. The occlusion balloon is obviously on the outside of the endograft. At that point, you can deploy the main device and the ipsilateral limb, and then go back up through with a second balloon occlusion balloon from the ipsilateral side, and swap out, bring down the occlusion balloon that was on the outside, and exchange it for a contralateral limb, and then proceed with your contralateral limb deployment, and then switch back to, if the patient is really still hemodynamically unstable, you could still, at this point, replace the balloon on the early contralateral side, and then finish your ipsilateral deployment to achieve endosseal, which should stabilize the patient for sure. Some other techniques in the endovascular realm that have, I think, helped, but are not necessarily all talked about. The percutaneous pre-close technique, which we use for elective AAA repair, is another technique. And then if you have truly unstable patients and don't feel like you have the time to do the pre-close technique, you can just deal with the sheath and by doing a femoral cut down after the procedure. Or recently published is the post-close technique, which allows you to downsize the arteriotomy with placement of a smaller sheath alongside of your pre-close, your per-close ProGlide devices, and then get to in there and able to obtain hemostasis without femoral cut down. Anesthesia techniques are another way that that ruptured AAA repair has moved forward, especially local. One of Lashat published back in 2002, and it was recently in 2011 reprinted because of the importance of this, showed a 30-day mortality of 9.5% in endovascular treatment of ruptured AAAs in 20 patients that were able to be completely treated with local anesthesia only. This was also confirmed with the IMPROVE trial with local anesthesia associated with a significant fourfold survival benefit compared to general anesthesia, even with adjustments. Which takes us to our last area that really has changed a little bit in the management with endovascular repair of ruptured AAAs, which is abdominal compartment syndrome. Its factors associated with the development of abdominal compartment syndrome include a use of an aortic occlusion balloon, coagulopathy, massive transfusion requirements, conversion of bifurcated stent grafts into aorto-uniiliac stent grafts. And ultimately, the recommendation of this publication is that these patients undergo vigilant monitoring for the development of abdominal compartment syndrome. Dr. Veith was part of a large publication of 102 patients that were treated with endovascular repair. And the definition of abdominal compartment syndrome for this study was greater than 20 millimeters of mercury. The overall 30-day mortality for EVAR was 13%. It was 8% for patients without abdominal compartment syndrome, and 30% for patients that did develop abdominal compartment syndrome. These are some of the techniques to manage it once you recognize it. And as far as the causes, it's a multifactorial cause, and the most important principles when it comes to abdominal compartment syndrome are prevention, early recognition, and early treatment. I'm going to show a quick case if this will start. This is a 76-year-old patient, large patient, who presented to our hospital on one of the novel anticoagulants. It's not there. Okay, sorry. He had a CT scan that showed a severely angulated short neck, definitely outside the normal IFU, but because of the fact he was on one of the non-reversible novel anticoagulants, we decided to treat him endovascularly. He was hemodynamically stable, but was symptomatic, and on the CT scan, which I unfortunately wasn't able to show, clearly had a significant amount of retroperitoneal fluid. This is, on the left side of the screen, is the initial angiogram, and then we were able to treat him with a Medtronic Endurant device. Hopefully this one will play. Strike two. Okay. Shows a very nice endovascular repair with no increase in the amount of retroperitoneal fluid. I actually have seen him back for his 1 year follow-up, and his repair continues to look very, very good. This was him post-op day 1. And when you think about where we've come from the management of a ruptured abdominal aortic aneurysm, going from 10, 15 days in the ICU to post-op day 1, a gentleman who's sitting up in the chair giving you a thumbs up, I think it speaks to the progress we've made. So in conclusion, improving outcomes in ruptured AAA requires an institutional and regional support, a team approach, and team commitment, and it requires skilled, equipped, and thoughtful surgical and anesthesia team. Thank you.